Okay. Thank you for coming in. All right, so what this session is about is the Unicare Pilot program using the Vinnani heart failure and COPD pathways. This session is going to go through the pathways for CHF and COPD, which many people are already familiar with, and so we want to just walk through those again. I'm not going to read directly through them, but I am going to point out some things that in the pathway that generally I think we're not really doing, and I want to make sure that we're following through with those because they need to be done for Vinnani and they need to be done for the pilot program. So I'm going to talk a lot about what that pilot program is and the process on that. I do want to let you know that we have a task force for hospitalization that has just started meeting again. We do want to have field representation as well, so your manager should be reaching out to people to become a part of that. And so, no. So what we have discovered is when we looked at some of our data, because we're very much closely looking at data, who goes into the hospital? The COPD patients. So if we have COPD and heart failure patients, sorry, both of those cardiopulmonary type patients will be going into the hospital as well as neoplasm. And so our palliative patients could be contributing to our hospitalization rate. So we're going to be looking at them separately. But when we put together our heart failure patients and our COPD patients for the last quarter of time, the quarter two in 2016, over 33% of them went back in the hospital. So you three right there sitting there, one of you would be going back into the hospital if you were one of our patients with CHF and COPD. So that's not good, right? That's really not acceptable. So you win a third of our CHF and COPD patients. So we're really looking at that 60-day hospitalization rate because it cuts across our, it's publicly reported, and it goes to our star ratings, and it goes to our value-based purchasing. So we need to focus in on these patients. So it's really important, not just because we're having this pilot program with an insurer, but that we are actually addressing all of our CHF and COPD patients. Okay. There is processes up that's on the wall that right there that I know the clinic can't see, but looking at things like that, things that we should be doing to try to keep patients out of the hospital, like consistent clinicians, like following our protocol, following our pathway, getting our case manager in there in the first week, putting telemed in there, making sure we're having our case management meetings, making sure we're making our specialist referrals, and making sure our liaisons are coordinating with external case managers to get patients on and making that transition really well, using our hospitalization risk tools in SHIP and in Mobilize, and our hospice identifiers to see in SHIP who might be more appropriate for hospice referral, and also doing chart reviews on all of our patients that have been hospitalized. So these are processes that we listed out in the task force that we should be doing. These are not new ideas. These are things that we should be doing. So we're looking at data right now to see, are we doing the processes that we should have had in place already? So in the first 2 weeks of July, which I know it's summer, but the first 2 weeks of July, and our case manager in the first week was at 70% for these patients. So is that good enough? Do we think that's good? I mean, we're going to try to set some goals on this, and we're looking for more data on these other things too, like are we putting telemed in there? Is it getting in on the second day? So we want to just, we're doing a lot of assessment, and then we're also going to be starting to think of some new things. So if anybody has any ideas or anything, please make sure you're coming to me, coming to your manager. We really need to focus in on these patients. So that's my little spiel for a little introduction, and now I can't move my... Yes.
If we have the high-risk patients for going back into the hospital,
yep,
putting in nutrition consult, MSW, palliative, all of it, does that help even if they go back into the hospital? Is that still a thing, or is that?
Oh yeah, you know, if they go in the hospital today, I mean, that's if they go in the first 60 days, our 60-day hospitalization rate for our Medicare patients, if they went for no, even if we did the best we could and they went into the hospital, that counts. The only time it doesn't count is if it's at a scheduled admission. Okay.
What about uncooperative doctors?
We're not, you know what, we will run over if I continue, but keep thinking about these things. Yeah. We can only do the best we can. I will say we are not looking for our hospitalization rate to be 0. There are people who are going to go into the hospital, and that's where they belong. They should go into the hospital. They need that care, that level of care. But a third of our CHF, COPD patients, do they really need to go into the hospital? Is there something we can be doing? All right, so I want you to be thinking about that, okay? So today we're going to be going over the Unicare Pilot process. We're going to be going over the pathway and just making sure that we're starting to really utilize that pathway. there is only one really kind of real new thing for us to learn about here, and that is assessing patients' health literacy. We're also going to talk about Teach Back and SMART goals, and these are parts of the pathway. So let me tell you about the pilot process that we have going on here with an insurer. The insurer is Unicare, and it is does a lot of our state workers. So we have this. We are part of the Visiting Nurse Association of New England as one of the agencies within that, and Venani actually set up this pilot process to try to take care of these patients. These patients, since they are maybe working, they are not homebound. They are just, they're coming to us with CHF COPD, that they're going to come to us in two different manners. We have two of these patients on right now, and Cassandra Oman is actually the case manager for them. Both of them have come from the hospital setting and has come onto service with us. So they're actually coming onto service in the normal manner. All right, we get a referral. We know that that person's tagged as a Unicare patient, and we want to make sure that we are doing everything on the pathway that we're supposed to do. Because why we have this pathway is that it's standardized practice, so that everybody in Venani, all the different agencies, when they have a CHF patient, when they have a COPD patient, they are using this pathway and standardizing our practice, so that Unicare knows that we're all doing the same practice, and we're working together to keep patients out of the hospital and out of the emergency department. Those are the primary goals, right? Every time a CHF or COPD patient goes into the hospital, has an exacerbation, their disease process worsens, right? They don't come back better from the hospital, right? They are usually on that cycle of decline. So we want to, it also costs money, but if you think about it from a patient care standpoint and providing really great care to these patients, if we do have to send them into the hospital, is there something we could do about that, because it will just continue their cycle of decline, and can we stabilize them? So the patients that have been referred to us so far, there's 2 of them that have been referred to us from the hospital. At the end of August, Unicare right now is identifying 100 patients that have been in the hospital or emergency department in the past 6 months to a year. They are identifying those patients. They're going to give the names of those patients to Venani. Venani is going to take those patients, and they're going to say, okay, these patients are in the NDNA and hospice's geographical area. Those names are going to come into this secure portal, and then we are going to actually need to contact those patients to try to schedule an assessment with them. All of that contact and back stuff is happening. You don't have to do that at all in the field. We are doing that in the intake department, and the liaisons are probably going to help us too, to make phone calls to try to contact these people who may not be home, right? Because they might be working. Maybe we need to contact them in the evening. We need to make contact with them, and we need to track whether or not we get those patients what's called engaged in the program. So we'll take care of that. Once they become engaged, then we're treating them like we just had a patient that just come on service. We'll get orders from the physician. It's now a patient that wasn't hospitalized that's coming on, like it's from a doctor's office kind of type referral, and we're going to go out there and we're going to do an assessment, and we're going to assess the patient and determine what their needs are, and we are going to determine how often we need to go out and see them. And there is a grid that I'm going to show you about sort of an authorization kind of grid for the number of visits, and we'll talk about that when we get to that.
So they don't need to be home.
They do not. They are not Medicare. These patients do not need to meet Medicare eligibility criteria. They have been identified by the insurer. You're kind of like that case manager on the insurance side that's saying, hey, we have this great program for you. Can you want to participate in this? And we are trying to get them to say yes. And if we say yes, we go out and we assess them, and we try to get telemed in there, and we try to get any other services in there. And then, and I'll go over the visit frequency orders in a second, but we have to follow the pathway, and we have to do certain things in the pathway.
And do phone
and at
calls,
the end,
phone call intervention
contacts,
count?
they do count as contacts for us. What's the primary goal here?
Keep them out.
Keep them out of the hospital and the emergency department. So whatever we need to do, they're pretty prepared to do it. So this is the visit range, and you do not need to memorize this. Okay, so as soon as we get let me tell you, as soon as we get a Unicare patient, we're like, flags are like, hey, this person's our Unicare. We got to make sure we're paying attention to this. But you should know that you are going to make a decision when you do an assessment, and the nurse is going to do the assessment. It's going to be a nursing assessment. So is that patient at moderate risk and only needs about 4 weeks worth of time to teach them how to manage their disease to keep them out of the hospital? Are they more of a high risk where they need 8 weeks worth of time? And we can provide all the different services. If we don't need to have in fact, this is a pilot for us too, because our protocol is for hospitalized patients, right? I mean, we want therapy in there, we want everybody in there, front loading and all that kind of stuff. Well, I'm not so sure that's really going to work for these patients that are more, up and out and moving around. What's our goal for them right there might not be to put PT in there. Maybe that's not what we really need in there, but we definitely need Claire as a nutritionist or something. We're going to make some decisions about that patient. We're going to discuss it. And then we're going to determine how long do we think we need to spend with that patient? 4 weeks, 8 weeks. If it goes over 8 weeks, we have to ask the case manager to be able to go far more than 8 weeks. But as long as we're kind of within these visit ranges, then we're good. If we need to give extra time, let's say, patient fell or something like that, we have to put more services in there, then we would want to contact the case manager. But we will be on this to make sure that you understand and communicating. And Kim Ann is also involved in this as a part of our authorizations. Okay.
If they're working, can we do weekend visits?
We should be able to. That's exactly what we need to be, as flexible. We may need to do evening visits. We may need to do weekend visits, and we want to get telemed in there. We will be getting paid extra for the telemed. Every day that telemed's in there, we are paid extra. We want to be using that telemed to make sure that the patient is learning how to manage their disease. All right. So that's kind of the visit range. So we're going to go through the pathway. I just want to remind you, these are things we should be doing already. Intake right now is looking for information. They're getting as much information about the H&P, the discharge summary, the medications. Are they looking for things like the COPD staging? That's something that they need to try to get, if they can get that, if maybe it's in the discharge summary. If they can get any idea about teach-back readiness, not so sure they're going to get that, but if they can get that from the hospital or any type of hospital, if the patient has been in the hospital, a risk assessment tool. So they're going to try to get as much information from the hospital, if the patient's coming from the hospital, from the primary care physician if we are engaging that patient via that portal system and as somebody who's not hospitalized. So they're going to try to do that for CHF patients and for COPD patients. This is just for CHF, and this is looking for the classification or their ejection fraction, so we can get as much information as possible to take care of these patients. We are also going to incorporate the pathway call, which is already being done for all CHF and COPD patients. That's that call that's happening the evening before or the day before the initial visit is made with that patient, and that's very specifically for our hospitalized patients. I think if we're going to be calling from an intake department already to try to schedule an assessment, we probably don't need to have the same pathway call to somebody who's up and mobile. So we may be looking at some different things. Again, this is not something that you guys are responsible for, but I want you to make sure you're reading those call logs that are in there for the Venani pathway call, because it does have hopefully some information if they did get through. And it's also an opportunity, especially for our patients that were hospitalized, to be seen that night if we need to really make a visit for some reason on those patients that in the evening as opposed to the next day. Okay, so that's not new. You have a copy of your pathways, so if you can just look at your first page of your pathway. So I want to remind you, this is our assessment column, the teaching and the outcomes, right? And then this whole first section here, this is our complete cardiopulmonary assessment every visit. What are we trying to do? Keep the patient out of the hospital by looking for those subtle signs and subtle changes. So we want to be checking their vital signs every time. We want to be listening to their lungs. We want to be looking at their weight. We want to be looking at all these different things. How about their activity tolerance? Is that changing? And trying to identify, is this person at risk for going to the hospital before the next time I see that patient, and why? Why will this patient go in now? And we need to put interventions and in referrals, something in your best judgment. What can we be doing to try to keep that person out of the hospital? It might be that we're going to make a phone call to them, or we're going to make a phone call to the caregiver to follow up. Are you taking your medication correctly? Are you following these different, whatever it is, it's going to be specific to that patient. But if you can always be thinking, why might this person go into the hospital before the next time? Do I need to move my visits around? Maybe I need to make sure that there's a visit over the weekend or a call over the weekend. What is it? And so the teaching section is the zones tools. So you're all familiar with the zones tools. And you guys, I don't know if you can see the zones tools out there in Pine Hills, but this is CHF and COPD. These are our primary teaching tools as an emergency plan for our patients. Are they going into the yellow zone? Do they know what the yellow zone is? Do they know what action to take if they are in the yellow zone? The action might be, of course, call us. There's a 24-hour, 7-day-a-week patient, the nurse that we have that can call, and it's not a problem. Make sure that they understand that that's a part of how we do business, and that these were just out on the table. You all should be familiar with the zones tools, I would think. I'm not going to go through them. Yeah. They're all on the patient teaching shelf. Please make sure you have them with you. They're also in the packet that goes out to the telemed, with the telemed, right? And we also have the two CRAMES booklets, one on heart failure, one on COPD, that is also on the bookshelf, but also should be going out in the telemed packet as well for our teaching. And that will go through the signs and symptoms and education that we should be teaching our patients. So that is that emergency plan. That person needs to know what they should do and be able to explain back to you, or bring up teach back. They should be able to explain back to you, this is a problem-solving thing. What would you do if you gained 3 pounds? What would you do if? Those are great questions to ask patients, because then you'll see whether or not they would have the right reaction, the right ability to problem solve. Tell me what signs you're looking for. Can you explain to me what signs you would be looking for that you are not doing as well? And those, again, that subtle signs is what we think is going to keep the patient out of the hospital. All right. I also want to remind you that you do have the ability to have the patient use an a cappella or aerobica, I think, or Arabica, or whatever. That there's another one out there that's a aerobica, that there is information on the MDNA resources on iTacit about that. It is still a positive expiratory pressure device, which splints open the airways and vibrates and helps to move secretions to come out. Very similar. It's just, I think, a different kind of brand. Okay. Okay. So one of the things, this is an area that we have not been focusing on. We have talked about health literacy in the past, but we're going to just watch a video on health literacy, and then we'll talk a little bit more about a tool. Jamie, can you turn the light out? I think it will be easier for Pine Hills. Can you see the screen okay?
Yes.
Okay.
Americans are struggling with modern health care. It's hard to be a patient these days. What's it like to be a patient? What challenges do they face? I want you to meet some people. They'll show us just how complex and overwhelming health care can be.
Well, I'm a kidney transplant. I've had the transplant for about 15 and a half years, but I've been sick forever. Okay, well, I take baby aspirin, that's something new, cyclosporin, prednisone, and when I make the doctor's appointments, I have to be sure that it doesn't interfere with his doctor's appointments, my doctor's appointments, or their doctor's appointments. So you don't like to go to the hospital where they give you a lot of papers to fill out?
Paperwork to fill out.
Paperwork.
Yes.
Why is that?
Because I can't read that good.
Because you can't read that well. What does it feel like when somebody hands you a lot of paperwork and you can't read?
I feel like you're in another country.
Vitamin D, Nexium, Norvasc, Prolistic, Estratest. When you enter a doctor's office, the first thing, and your first time patient there, they're going to give you a clipboard. Sometimes. But it is very discouraging for a patient who cannot read. Lipitor, Paxil, Darmstadt, Vitamin E.
If I'm really embarrassed or confused or worried about things around me, or worried about my child being all upset, I would not be able to read things I normally would read every day.
You know, some of the words that the St. Jude, Brown, plastic, and all of that, what, is that several things or one thing? Or it's just a language that I'm not familiar with.
If the patient was transferred to that facility and to any and all insurance companies or other third parties paying or obligated to pay, this is not making any sense. Tums, Tegretol, Tenormin, sodium bicarb, Cardura.
Do you have any idea what a normal blood pressure is?
No.
Any idea?
No. It's no.
No, it's not normal. It's hot. Have you or anyone ever had to sign a consent form?
Yes.
I have hereby okay, authorized
My calcium spray, nystatin, Aricept, Lasix, Ambien, Imodium when you need it, and vitamin D. I believe that's it.
See, you know these people. And even though they represent all education and reading levels, they have one thing in common: low health literacy. It's so easy to make harmful and costly medical mistakes. Just listen to what they have to teach us.
So what you do, you come out of that room, that examination room with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine, because I did not understand anything he or she saying to me.
When your children have fever, what do you usually give them?
Motrin or Tylenol, normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
So you give her a tablespoon and a half. Can you find where it tells you how many you take? The dosage?
Three or three?
Take 3 to 2 milliliters. And there's something I want to point out. I don't actually read this because I know what it says now. So if I had found it out, if there was where I knew it, because I've heard it so many times, I would not be able to read that. Okay. Every 3 to 4 hours as needed for pain.
Okay. What's milliliter?
I don't know.
The medication that was given to her was not explained. Well, we didn't use it. Is that she ran out of her high blood pressure medicine? So she didn't take it. She didn't call me to tell me to fill it. So finally I found out that she had not been taking it. I said, Mother, you can't do that. You have to keep taking that high blood pressure medicine.
And then it says discontinue. What does that mean?
I don't know.
How many times do you take these thyroid pills?
Once a day.
Okay, you take one of each of these?
Mhm.
Okay, so you take 2 thyroid pills.
No, I take one. I'm more likely got it messed up when I got refilled. And then, are these stickers helpful?
Nope, don't even look at them.
Don't even look at them.
What do you take that medicine for?
I don't think so. He just puts me on stuff and you tell him I just take it.
Low health literacy is catastrophic to patients, their families, and to our healthcare system. Millions of Americans struggle needlessly. Their misunderstanding leads to medical mistakes. These mistakes lead to hospitalizations that we could avoid. Simplifying material alone will not solve the problem. Funding is needed for health literacy research and... Okay, I'm going to pause there. Jamie, if you can turn the light back on. Thank you. Okay. So I just want to point out it's not just about reading. If Bob told you how to manage the server, would you know exactly what he was talking about? Would you understand it right away? Would you know the vocabulary? Another example is Jeff. I don't know if you noticed, he had his shoulder surgery on his shoulder. Okay, so he has been asking me. He goes, "What's this ROM?" I'm like, "Oh, it's range of motion." It's like, "What's range of motion?" Right? These are terms that we're like, it's like in our vocabulary. You know, we don't think about that. You just see it. You know exactly what it is. We all have terms like that, but he didn't know what that was. And so, and he can read, and he's a pretty smart guy, right? So think about that from a health literacy standpoint, that with all the information that we're trying to provide our patients and our caregivers. It's not just our patients, it's the caregivers as well, and how overloaded they are and everything. And so one of the things that we haven't focused on as part of the pathway, and it is a part of the pathway, is assessing health literacy. So there is a tool that you have in front of you, which is, where do I have it? Here we are. It's called the Newest Vital Sign. There are 2 pieces of it that you have. One of them is a stapled thing that's called the Newest Vital Sign, and the other one is a nutrition label. Right. We're going to take 5 minutes to just have you read through this tool. I want you to feel like you understand it and you've gone through you know, the pages on the instructions, and that you've actually looked at the tool. Right.
We're doing climate reading. This would be so hard. We're not good. Oh, for you, for you. Yeah. I'm just thinking more like okay. And this is way bigger than it is on the end container. If you think about it. Just take I don't understand. He's like, every time she has me, she gets me with her.
Okay, so you should have a stapled portion that goes together, and also you should have the label. And what I went back and forth on is whether or not I should laminate it and how but I didn't want to laminate the quiz to the other side of the you have to have like two different pieces of paper. So what I did was I decided to hand out one of these sheet protectors, and then what you can do is you can take out your quiz and you can be looking at it, and then you can hand the one with the sheet protector to the patient so that they can be looking at that. Have one that lasts a little longer. But let me know if it's something different, if you have a different idea of how that you might want to use this. But that's what I'm thinking about it. This tool let's go back. The Visiting Nurse Association of America did a presentation and research about health literacy and decided that this was the best tool to use. That this was, we're trying to use a standardized tool to assess this, and this was the best tool to use. And then the Visiting Nurse Association of New England has put that we need to assess health literacy as well, and they're recommending that we use the newest vital sign. This was one of the things that we, when they came and trained us, and actually Jerry and Mary Beth were both in the training, that was one of the things that they brought as a tool. What do you think of the tool?
Maybe you don't.
Yep, wonderful, oh my gosh. Good plan. So what, this is actually, because Cassandra Ullman made a decision on her own. What?
Sandoval.
Oh, Sandoval, oh my God, sorry.
We lost her.
Oh my God, oh no, sorry. Sandoval. Anyway, she made a decision that was probably in the narrative is a good place to just put it. So when are we going to do it? So there's been, it's funny how every class is slightly different because, and maybe I don't know if it's the way I presented or differently, but that was one of the questions that came up. Is too much to do right on start, you know, like an admission visit? Yeah, it probably is too much to do on that admission visit. But in these patients, we're doing a second visit that next day, right? The best person to do this is the nurse in the case, because a nurse will always be in one of these cases, right? And so we want that nurse to be able to do that. Only one person should be assessing this. We don't have to all go in there and assess it. We're going to assess to see what's happening for that patient. And probably maybe the second visit might be a time to do that. And I want to remind you, do not, I mean, the patient, it says right in there, if you're spending time, they can't answer the first question or the first two questions, you're done. So, and there's a way of sort of introducing it. So some of the barriers that came up in the other classes was patient dignity, like feeling like they would be feeling kind of stupid if they couldn't answer these questions. Okay. So I don't know, can we deal with that in a way of the way we present it? Everybody right now concerned that if you can't answer these questions, you might have some difficulty understanding some of the other things that you need to manage. So I might present the information to you differently. You know, now that we know that you're having some difficulty with numbers or reading. You know, these are things that we don't expect everybody to score high on this. We are using this as a way of screening that this person really has low health literacy. And it may be that they're fatigued, you know, they just came out of the hospital, they're in pain, that they're having difficulty thinking too. Well, they're going to have difficulty with following any of the other information that we're telling them too. So this is a tool for us to be able to use to identify those patients who are having difficulty understanding health-related information to try to manage their disease. One of the other ones that came up was a shorter screening. Again, you can stop that testing right away. Another one was why an ice cream label? Why not a medicine label? Something different. This is the standardized tool that they did testing on. So this is I do not think there's another tool. I did actually ask Andrea Foley did a whole presentation on health literacy for part of her master's program, and she said this is the standardized tool for assessing health literacy. Also, one of the other issues was that it's very auditory. You know, you can't really show the questions. So when you're reading them, you're really asking. You're asking the patient that. So that might be a barrier as well. So those are some of the things that we identified. Also, we talked about where we might be able to document it in the attributes as well. So right now we're going to start with putting it into the narrative, but in the attributes, you can add attributes in there. Health literacy is not one of them, but maybe we can put low health literacy so it actually shows up in the attributes where in the overview tab. So that's some place to look at. So right now I see this as kind of a pilot for us, and how can we incorporate doing this? What do we find? And this is a data point that I actually need to report back on the Unicare patients, and on all of our CHF COPD patients, I need to do chart reviews to make sure that we're following the pathway and report back to, not on every chart, but like 10 charts every month or something like that I have to do to make sure that we're doing this. So I think that narrative is the best place. All right, this is something that we think we can do. I can't read it. Oh, the patient scored, she just wrote out, the patient scored a 0 on the newest vital sign health literacy assessment, suggesting high likelihood of limited literacy. Oh, cool. I don't think you have to write the entire sentence out like that, but you do want to get what the score is and that the patient has limited literacy, or they're have good health literacy. Okay.
This is a really stupid question, but
Is this for all the CHF COPD patients, not just Unicare?
Correct.
Okay.
It's not a stupid question at all, because I'm kind of a combination on here that we really should be following the pathway, and Unicare is kind of over and above that, but we should be following this pathway for all of our patients, right? And Unicare has just a couple other things like how often the visits, like short-term, medium-term, that we need to get back. But we are following the pathway, and this is a piece that we have not been doing.
And I think if you sort of broach it and say to them, so this is the newest vital sign, they probably would be open to it, right? Mm-hmm. They all know what vital signs are.
Right. And this is something, yeah, and standardizing it too. We ask questions about depression. You know, we say because we don't necessarily think you're depressed, but we have to do it as part of our assessment to do that because we're screening. This is a screening tool for us. You know, and we do a whole Braden scale. We actually look at all. You know, we have people. We look at their skin, their whole skin, and that can be also a dignity issue. You know, so how are we broaching that? How are we going to broach this one? How can we incorporate this one? And what information can we get from it? Are we going to find that every single one of our patients have limited, really low literacy? We might, but that's also an eye-opening experience for you guys too. So I'd like to know how it's going. So if you can get back to me and let me know, that would be wonderful. Okay. All right. So let's move on to the second page of your pathway. So again, right at the top of that second page of the pathway, I just want to make sure that here. We have the learning ability. So we are not just clinicians out there, we're teachers out there, right? We are teaching somebody how to take care and manage their disease. So we need to know about their ability to learn. Health literacy is in there. Also using techniques such as teach back and SMART goals to try to move people along. We're going to watch a little video on the teach back in a second. Making sure we're installing our telemed units on day 2 for all of our patients with CHF COPD. That is a component. And making sure we're doing MedRec, that we're using, there's an ICE tool, the identification, clarification, and education tool that we should be using to make sure we're looking every time that the patient is taking their medications. Every time we go in to see that patient, we should be making sure that they're taking their medications correctly. Doesn't mean we need to pull out every medication every time, but certainly there's high-risk medications that we need to be making sure that they're taking, because that could send them in the hospital. Having end-of-life conversations, checking their exercise tolerance and their nutritional status. Do we see issues with that? Do we see changes that could indicate that they are having an exacerbation if they're suddenly not able to do a certain activity? Okay. So let's watch this other video on teach back, and then we'll talk about that. Thank you.
Well, Jack, good to see you. I'm sorry your wife wasn't able to join us today so that we could talk about all this today. But I do want to discuss some things that you can do to take care of your heart. And I have a booklet that I'm going to review with you and that I'm going to give you to take home that I think will be helpful. So are you checking your weight each day?
No, I don't. Do I need to?
Yes, it actually can be very helpful. One of the things you'll notice when your heart isn't pumping well is that extra fluid may build up in your body. And that fluid is heavy. So what you'll notice when you start building up fluid or holding on to fluid is your weight will go up. And by checking your weight each morning, after you go to the bathroom, but before you eat and before you get dressed, it can be a good way to see how things are going.
What would I be looking for?
That's a great question. What you'd be looking for is a sudden increase in your weight, say 4 or more pounds in a week.
Okay.
Do you have a working scale at home?
Yes.
And it sounds like you'd be willing to check your weight each morning.
Yes, I could do that.
Great.
Write it down.
Wonderful. And I've got a spot here at the end of the booklet, a place where you can actually write it down each day.
Okay.
So I think we've got a good plan how your heart's doing. And since your wife wasn't able to join you today, how are you going to explain this to her when you get home?
Well, the heart is not pumping correctly. Fluid might build up, and the fluid is heavy, and so I should be checking my weight every morning. After I go to the bathroom, but before I eat, and I should write it down.
That's great. And When would you think you might need to make a phone call? Do you remember what we said was the target?
Oh, well, here it is. If my weight goes up by more than 4 pounds in 1 week, I could call in.
Wonderful. That's a great plan. And when do you plan to start checking your weight?
Tomorrow morning.
Fantastic. So what other questions do you have for me?
I can't think of anything right now.
Great. Thank you.
Jamie, can you get that light? Okay. Get out of this. Okay. Just want to make sure that I don't have that. Playing another video. Okay. All right. Who feels comfortable doing teach back? If you don't feel comfortable doing teach back, then come see me and I'll work on that with you. Some people, it's a new, you're asking questions like, do you understand? And patients are saying yes, and you're off going, and you said I did all my teaching, and really you didn't close the loop on it. You didn't decide, didn't find out whether or not that patient actually understood. I don't actually think we should call it explain back, because teach back to me sounds so like teachy, like I'm testing you kind of. So I like to use the word explain. Can you explain to me what you will do if? Can you explain to me the signs that you're going to look for? It makes it a little more conversational. I just found that works better for me, but you'll have your own way of doing that. It doesn't have to sound exactly like that, but you just want to make sure you have a good understanding of what the patient understands or what the caregiver understands. Because they're not being necessarily non-adherent or non-compliant. It might just be that they just didn't understand and they understood something different. And then the what questions do you have opens up that patient or that caregiver to ask you the question. You're ready for them instead of just saying, do you have any questions in there right away? No, I should know how to do that. So being very open with that and identifying that. And that's something I'll be looking for in the documentation as well, just looking that you're using TeachBack to teach things such as the zones tool. And that we have a good understanding from the patient and the caregiver. Okay, again, coming to me if you have any questions on that.
So in the teach section, should we put verbal and teach back?
Verbal or using the teach back technique, or it would be in the teach section that we could document that you used teach back. Yep, and you know what? You can say I use the teach back technique, and you can even be specific. They was able to explain back the signs, but not the actions. Something like that. That's going to be helping the next person too, right? To be able to go into the teach tab. So why do you document in order to help? I always did anyway. Like if something happened to me and somebody else had to go in that next time, that you want that person to be able to follow up and pick up wherever you left off. So you can say I use the teach back technique to teach it, and that they were able to teach back something, or maybe the whole thing. And then that person knows that the next person coming in, the patient has good understanding. So this is the last page of the actual pathway, and that goes through things like home safety assessment and referrals and discharge planning. So we definitely want to make sure that we're doing our falls teaching, that there is another Cranes booklet on falls that we can be bringing out. Many of these patients are at high risk for falls, making sure we're making all of our referrals as far as like different services going in there, as well as things like adding extra telephone contacts, or if referring out even to a pulmonologist or a different type of physician or to our nurse practitioner to be able to maybe deal with the physicians. If you're having an issue with contacting physicians, maybe we need to have Donna Siebert going out and seeing some of these patients, or Nicole being kind of intermediary if you're having issues with not being able to get good orders or good communication with physicians. And then this is a suggested frequency. Visit frequencies are here. These are contacts. And these go along with making sure that we're seeing the patient and we're contacting the patient on a regular basis. I think we're pretty much doing these contacts. One of the things that we are talking about doing, though, is maybe a 2-week phone call, much more clinical oriented, and also doing a quality call, which is more of a satisfaction. So trying to incorporate that into our patients so that we can try to keep them out of the hospital and identify issues that they might be having, then we'll go back to the primary nurse, or maybe we need to do a visit out there, right? And of course, the contacts from telemed are on there too. And then our hospice eligibility criteria are here for those, so you can take a look at that. All right, so we need to medically manage our patients. We know that they're sick, they're coming out, they have a lot of different medication changes and treatments that they've had. We need to make sure that they are stable and medically managed, and we're assessing them, cardiopulmonary assessment, looking for those signs and symptoms of change. But we also need to be addressing their behavior, because it's their behavior on their ability that affects their ability to manage their disease. You are going to have, we're going to talk about some behavior change. You're going to have patients that these techniques that I'm going to talk about right now, they're not really going to work for that particular patient, but maybe they might work for the caregiver. Things like assessing importance and relevance. That is a adult learning principle. Somebody, as adults, we don't have time. We don't want to learn something if it's not important to us. Why is it relevant? If it's not important, I'm going to listen to you, but you know what? I'm not going to really incorporate that. So that is exploring whether or not if the patient feels something is important or not is a good technique to find out, because that's a part of determining whether or not they're going to follow through, or not necessarily have a complete understanding, but that they think it's important to follow through with it. Confidence is another technique, another thing that we should be assessing, which we're really not doing as a part of behavior change. So you can teach and teach and teach, and they have the knowledge, but if somebody doesn't have the confidence to incorporate a new diet into their, or exercise, or if they don't have the confidence and the ability to do that, then they're probably not going to be successful either. So to build confidence, we can use SMART goals. SMART goals are specific, measurable, achievable, relevant in a time frame, and a certain time frame, which is usually not more than a week. So there are several tools on the SMART goals tools that we have. Some of them are on the shelf right now. We have the 2 tools that go with CHF and COPD. We taught this session that these went through. Nobody's using these right now, I know that. So let's maybe think about using them as a part of our SMART goals. We also have another tool that I put out, which is more of a generic SMART goal tool, which might be better. So it kind of walks you through helping somebody set a goal. So before we even set any SMART goals, what we have to do is determine, what does the patient want? What is the patient's goal? And that is sort of your overall goal. So we need to have that that listed in the documentation, so everybody knows the patient's goal is to get to their granddaughter's wedding. The patient's goal is to sleep upstairs again. The patient's goal is what? And that's really important, because that's what we're there, is to help them achieve what their goal is. And then we have a tool to use to try to help them understand some importance as why it might be helpful for them to limit the salt intake in their diet, so that they don't end up back in the hospital, so that they can get to their granddaughter's wedding, right? And then we can start setting some SMART goals with them. And so I want to just point out one other thing here that I attached to your pathway. On the back page of your pathway, it is assessing importance and confidence. A while ago, we gave out a ruler, so some people may have that ruler still, but you can just use this, or use a scale of 0 to 10. On the scale of 0 to 10, how important is it for you to do those exercises? How important is it for you to follow this diet? How important is it for you to stay out of the hospital? So using those language, if a patient is a 7 or above, that's important to them. If it's down really low, it's not important. If somebody says it's a 1, it's not important for them to limit salt in their diet. Then what are we going to do about that? Because we think that's really important. We think it's really important, but they don't. So we can teach and teach and teach, but they're not going to do anything about it. Maybe we need to try to have them understand in a different manner of our teaching on what happens when they do put more salt in their diet, the effect that it actually has on their weight. So we're using that as a teaching tool to try to improve importance in their level of importance. Their level of confidence is also something that we can be doing on a scale of 0 to 10. Somebody who's 7 and above, they're pretty confident that they can do something. If they're low confidence, they're probably not going to be able to follow through on it. So we look at our profiles down below. We have the low importance, low confidence person. These people are either see change as important, nor believe that they could succeed in making such a change if they tried. These people are going to have a hard time. How are they going to manage their disease, right? And this could be a caregiver too. So we have a lot of patients that have dementia. We're not going to be able to teach them how to manage their disease, but somebody has to learn how to do that. So if there might be a caregiver as well who doesn't see the importance in something, who is not confident in being able to do that. So we need to build those. We can't just keep teaching, but we need to assess the importance and confidence. Down the other corner here, we have our high importance, high confidence. These people see it as important to change and also believe that they could succeed. This is somebody who's going to take that action plan, they're going to do it. All right, they're going to be those successful patients, right? They're the easy ones. right? Then you have your low importance, high confidence. These people are confident that they could make the change if they thought it was important to do so, but they are not persuaded that they want to change. So they think they can do it, but it's importance that is the issue. Whereas the other one down here, high importance, low confidence, is not the problem in the willingness to change. For these people express the desire to do so. The problem is low confidence that they could succeed if they tried. One of the ways to build confidence is, I'm not going to be able to have time for that, is to actually set SMART goals. So SMART goals, this is the tools that we had, I was just having you look at. On the top we had put bubbles onto the heart failure and COPD, as these are things that that patient needs to work on to help manage their disease. Even something as simple as asking the patient, well, which one of these things do you think you want to work on? I think the most important things for you to work on are X, Y, and Z. Which one do you want to work on? And then starting to set a SMART goal. And the template will walk you through it. Either the generic one or the other one will walk you through it, where you're getting a very specific but achievable goal. This is not, let's stop using SALT. Just totally, right? Because then that's like taking that giant step to the top of that stairway, all right? You want to make it very small. So let's ask the patient how, if we're going to work on your diet and limiting your intake of sodium, how often do you think you want to not put extra salt on your food, all right? And they might say, well, I have to do it every day. They're like, well, is that achievable? Are they going to be able to do that? No, so let's make it more achievable. We want this to be a successful goal, because success builds confidence. So it might be 2 days a week they're not going to be adding that extra salt on, right? Also want to be asking the A part of that, the SMART goal is achievable. What's going to get in your way of achieving the goal we just set? So that's your way of kind of looking at where they might get tripped up when you're not there at that ahead of time. So maybe they're going to forget. Put a reminder, on the refrigerator. You're going to work together to try to make this an achievable goal. I know we don't have time to go through this. I'm going through it very fast. Some people have had this training before, and other people haven't. We are going to circle back to this. And would love you to just try to make sure that you're looking at using some of these forms, even the generic form, which kind of walks you straight through. Go ahead and use it for yourself. All right, so you just learned the health literacy tool. All right, so maybe using it on every COPD, CHF patient right now, you might feel like it's too big of a, you're not very confident that you're going to be able to, maybe you're not even thinking that's important. All right, but I'm looking for it, so maybe that's important for you. So how confident are you that you can do that? Set yourself a SMART goal and see and walk yourself through this. How about exercise? You all exercising 150 minutes a day? 150 minutes a week? Try to use it for yourself, and then you'll feel more confident in being able to use it with your patient. So again, we have medical management, and we have teaching the patient or the caregiver how to manage their disease. And that's what's going to keep them out of the hospital. We can try to be there. We could be thinking of things, but we can't think of everything. We need to get they're with themselves 24 hours a day. We need to have them feel confident in being able to take care of their manage. So at the end of all of this, and you guys going out and seeing these patients, I need to collect data. So some of the data that I'm going to be collecting on all CHF and COPD patients are the number of hospitalizations, the number of ED visits. I need to send some of that information to Venani. I need to send some of that information to Venani so they can send it to Unicare and see whether it was a successful pilot. Goals set by the patient. If I don't see any goals that the patient, even that's just the overall goal. Do we have a goal that the patient, are you using SMART goals to try to work with that patient? If I see that, then I can say yes, goals set by the patient. Self-supportive confidence to manage chronic illness at a 7 or above. So that is saying that by the end, in the beginning, you might ask, how confident are you that you can manage your COPD? And it might be really low, but hopefully by the end, we've improved their confidence level. And we're looking for that number of assessments we performed, the number of ones in the short, medium, and long term, and the number of telehealth placements. All right, so these are some things that I need to go through. You have another form that says a compliance tool for heart failure and COPD clinical pathway use, like this. That tool is actually the data that was sent to me from Venani that I need to collect, and these are things like the call logs that I need to check the call logs for the Venani pathway call. I need to know that health literacy was assessed, so I'm going to be counting that up. And then I'm going to be looking in that Teach tab for the use of the Zones tool and the use of TeachBack. And we could look in the narrative or the Teach tool if I happen to see something about a SMART goal and what the patient's long-term goals are. and have that documented in their confidence level. All right. So these are just a couple of new things here. The biggest new thing was that health literacy tool. But be thinking about importance and confidence in using SMART goals.
Do we have that piece of paper? Do we have that?
You don't. You have some of this you're not going to have to worry too much about. I just kind of threw some up there. Know that this is what the ones that I gave you, this one you have, this piece of paper, and of course, keeping those patients out of the hospital. I'm going to be tracking that as an agency anyway, and even the ED. So what we're trying to do is actually have our clinical managers, when patients go on hold, we're developing a tool, an audit tool for them to go and look right in that chart right away, so that we're not looking like when we determine if they went to the hospital or not. They went and sought higher level of care if they're on hold, right? Why? So we're going to be trying to analyze that. We'll get back to you with some more data. You have some more one-on-ones with your clinical managers about specific cases, because we're going to be looking closely at that. So we always want to be looking back. But of course, we want to be proactive. We don't want that to even happen at all, but we want to learn from the ones that you went to the hospital.
For urgent care, doctor visit or something like that on that level.
No, that would not be putting the patient on hold. So if we get a call, the patient is in observation. That's what we're going to be looking at. Case management meetings are things, we want the patient to be using the urgent care. We want them to be going to the MD, and that's not a higher level of cost or care that we would get, ding for that the patient would be in that diabetes downward spiral as much.
And I know whatever they're doing. Way a little bit here across the board, or does it not matter? Like somebody will call and they'll both have observations.
Well, we better send both of them, because both of those patients, technically they're two patients. Unicare doesn't want them to go in, but that's a pilot program, and we want to treat that patient well. And the Medicare patient is going to come out on our Medicare outcomes, which go across the ball when they're publicly reported and are evaluated. So I would like to try to treat all of our patients the same, but we are very focused on the hospitalization task force on our Medicare first episode of care, first 60 days to keep them out, because that's when we see them. That's what we targeted as the people that are planning to go in.
So you're just really triaging. It doesn't matter.
But we want to keep
it seems to be.
I think we need to have both of them seen. I mean, that's what I would say. I don't want to. I'm not going to pick somebody because they're insurance. I would look at their clinical status and say which one really, is needing somebody right now, or what can we be doing for somebody else. Yeah. Okay. Yep.
Quick question. If we have people who are COPD or slash,
yep.
what teaching tools do, so that you're not inundating, overwhelming them. Teaching tools, we already thought about having a kind of a combined COPD slash heart failure tool.
So you also, thank you for bringing that up, because you can actually take these tools and you can write on them. You can actually say, this is why you went in the hospital last time. It was actually this weight gain or something. I want you to pay attention to this. Or, you have a combination, so I'm just going to have you make sure you also report this. And you can add something in. We can make some changes to these tools. I mean, you need to really use them. And if you're really using them and the changes need to happen, we can make changes to them. We also think about the action plan. Maybe the action plan for the COPD patient is to first use their rescue inhaler, and then see if that works, and then call us, and so we can definitely make these really specific to the patient. Yep, and that's what we're looking for, because everybody is different. I mean, we're standardized but individualized. There's a care plan that we should be following for doing everything, but you're going to try to meet that person where they are, if that caregiver with the teaching, and you want to be making sure that we're just doing these two for that patient. So it is going to be individualized but standardized. Any other questions?
Shouldn't be in the ALF. And that shouldn't be in, I don't know. I know.
So patients coming back CHF and COPD into
everything.
Okay, so this is also, and I know that we've been working with our liaisons with more networking with SNPs, so that if somebody was in the hospital and we don't leave it there, it's just if they were home, can we send them into a SNP? Can we put them into a different setting if they're not setting them?
What I found with a couple that.
No, there's no discovery.
Yeah, they can come back.
You
So-
provide this service.
And then even if the SNF is questioning a discharge, they still.
Can you bring that up to at the hospitalization
Within
task force
3
to
days, they're
Noreen?
back on the hospital.
And that's gotten, recently it's happened.
Yeah, and I don't know
Past week.
why all of a sudden, but.
So
it
if you have
is.
particular names on those patients, if you can
Yeah.
let Linda know, because Linda's going to go to hospitalization task force tomorrow, and Noreen Cataldo will be there, and she can answer those
And
questions.
the thing is that the patient.
Or at least know about
I
them.
admitted her, and I did a resumption on
Who was it?
Micheline Ruth.
Sisson, SISSON.
Is there any questions from Pine Hills? Are you guys gone? Right, it's a post-course evals, you all have post-course evals, if you can complete those, and give me comments as well, and
Peruzzi, key.
you know how to
I have another one.
help literacy tools.
I haven't heard, so I'll discharge today if that's the story. I'll come in about 20 minutes.